Thank you, Libby. And thank you, everyone. What a great, rich discussion we've had to date, even going back to the 8 a.m. session. So thank you, everyone. So I'm moving on to our next session, which we are incredibly pleased to have. And I think it's in line with what was just queued up in the previous session around needing to meet the provider and be very provider-centric and having the entire panel covered. So we'll hear today from Dr. Michael Barnett, who will be helping to moderate our session. Dr. Barnett has been a really good friend of the eConsult Workgroup for several years, and an article that he published, and we'll go to the next slide, really caught our eye. But Dr. Barnett will be talking to us about advanced payment models and how eConsult is really a key stepping block for advanced payment models. We're also joined by Julia Murphy, who's the Director in Dissemination at the Peterson Center on Healthcare, and also Adam Whitlock, who's a Manager for Primary Care at Arkansas Blue Cross Blue Shield. Julia and Adam will be speaking to us about the groundbreaking eConsult program that they are launching with CMMI to provide a proof point for adoption of commercial business lines. And in addition, we're going to hear from Dr. Amin, who's the chair of the UC Irvine, the chair of medicine at UC Irvine, and he'll be speaking about their use of eConsults for all patients, including Medicare patients. So with that, if we want to go to the next slide. Let's see here. Thank you. So Dr. Barnett, again, we're so pleased to have you here. And when we read this in the Washington Post in May, it really, made a lot of our work really whole in knowing that we need to think about how eConsult is part of the entire telehealth strategy and hopefully will be thought of as the standard care practice going forward. So I'm going to hand it over to you. Thank you for moderating this session as well. Please take it away.
All right, thank you very much, Timmy. And hopefully everyone can hear me and sounds okay? Okay,
sounds great. Thank you.
Yeah, so, thank you so much for the invitation to moderate this panel. I have really admired the work of the eConsult Workgroup for a long time. You guys are my people, and the research world in eConsult is a very little tiny niche, but I think everyone in it is really passionate about what we do, and it's great to share this panel with folks who really understand what's going on. I have a few minutes for my soapbox. I know we're running a little bit behind, so I just wanted to share a few thoughts about eConsult Frontiers and my view on eConsults from kind of this academic ivory tower perspective. I'm also a primary care physician at Brigham and Women's Hospital and a user of eConsults. And one thing that really motivates me to continue to work in this area is that I just continue to be amazed by the lack of communication between physicians that are treating the same patient and the extent to which it's really just the status quo in medicine. And I really view eConsults as one of the key steps to stitching together our fractured healthcare system and just getting doctors to communicate with each other more directly than just simply leaving notes in a bloated EMR. And I'm really looking forward to the panel today focused on employer commercial plans with an ambitious eConsult rollout in Arkansas that we'll be hearing about, as well as eConsults in Medicare from Dr. Amin, and that population which is relatively neglected from the payer perspective for eConsults. And, where do we go next in the field? I think, everything that we've heard today, I think, illustrates that we need to try to put together a bunch of different puzzle pieces, right? There's the issue of provider engagement and in terms of graduate medical education and getting PCPs and specialists to actually use eConsult as its own tool as opposed to a way to just, order each other around or try to, just ask for things. There's payer alignment and the business model, which is also a challenge, and trying to make the business case for eConsult. And in Medicare, there's something we haven't talked that much about, which is patient cost sharing and what happens when patients actually need to pay for eConsult. Or, I doubt anyone here thinks it's a great idea, but that might be what some insurers think is necessary. And then with all these moving parts, how do we best assess the impact of these programs? think we're all very familiar with wait times and percent of e-consults resolved without a visit as metrics, but in my experience, that isn't really enough to necessarily move investment on its own. So I'd love to hear more about that as well. And then going off of our keynote speaker, I think there's also the issue of racial and social equity, which is that e-consults can be a tool for equalizing our healthcare system, but there can be unintended consequences, and it also can be a way of, in some ways, cementing a two-tiered system of specialty access, where those with the health literacy and connections to see a specialist in person are able to manage it, and others get an e-consult, which some may view as a two-tiered system, even though the level of quality could be maybe quite comparable. Before I move on to our really interesting panelists, I want to just make one more point about this technology and the business case, which is, even though we talk about e-consult as technology and health IT, I think of it really as just a mechanism to facilitate physician communication. And I say that a lot of my patients kind of assume that I just talk with the other specialists, and we just know what's going on. And in a way, it's just filling in a gap that I think patients just think is happening behind the scenes if they just think that we're doing our job. So, given that it seems common sense to my patients, what if e-consult doesn't actually save money? Would it still be worth it? An expensive new cancer drug or new orthopedic implant that extends lifespan by 1 month or has, X better performance on functional outcome would be covered by a lot of insurers. But why don't we consider covering cheap, if not cost-saving, delivery reforms that clearly expand the ability of physicians and patients to be able to have the right level of care at the right time? There's often, I think, a focus on needing to demonstrate that delivery reforms save costs, as opposed to delivery reforms that might be very cheap or cost neutral, but actually improve the delivery of care itself. So given all of that, I'm looking forward to hearing from our speakers, and thanks for having me here.
Terrific. And let's move on to Julia and Adam. Julia, if you wouldn't mind giving us an overview of your work that you're doing to date and the exciting, I think all of us are going to be looking with bated breath next year on the results as you are proving out eConsult in the commercial business line. So Julia, why don't you take it away? I think, Julia, you might be on mute.
There we go. Oh, you hear me now. Thank you, Timmy and Michael. It's a pleasure to be here and speaking to you all. This is our first time at the working group, so thank you for having us. A combination of Adam and I will walk you through the work that we're doing in partnership to further support scale up and spread of eConsults. We'll share with you our entry point into this work and how we came to focus on eConsults as a high impact solution, our vision for success for this work, why Arkansas, and then some specifics on the program itself. Next slide. Thank you. So the Peterson Center on Healthcare was launched in December 2015, and primary care was identified as one of our priority areas. At that time, we had funded Dr. Arnie Milstein at Stanford's Clinical Excellence Research Center to conduct bright spot research on primary care practices using claims data and observational study to identify the attributes of higher performance primary care that were leading to higher quality at significantly lower cost. As we learned into that model, worked on replicating it ourselves, and Arnie further dug into the research, we identified that within the primary care model, there was an area that was disproportionately affecting savings. When we looked at the data, 83% of the difference in savings between exemplary practices and average practices was coming from 3 areas. So inpatient surgical, outpatient surgical, and prescription drugs. That really led us to believe that the primary specialty care relationship is a high leverage point within this model because of the influence it has on planned acute care. At that point, we then dug into the evidence base more broadly to find solutions that were proven at enhancing the primary specialty care relationship, and came across eConsults as a high impact solution. Next slide. We looked at the literature and talked to partners and others to understand why eConsult as a high impact solution, although was being scaled within certain populations, what were the key constraints to support further scale up and spread of that, and really came to the perspective that reimbursement for commercial beneficiaries was a key constraint to that further scale up and spread. And so the strategic vision for this work is really to drive that further adoption by demonstrating if there is a business case for reimbursement for commercial beneficiaries, while also expanding the evidence base to demonstrate that eConsults does indeed improve access to specialty care, improves outcomes, improves experience, and reduces cost. While we were doing this work, we were also building our relationship with CMMI, who were very interested in the work that we had done with Arnie and are further digging into that to really focus on the primary specialty care relationship. And so we had the opportunity to partner with them in this work, and really, as we demonstrate this business case, also working within the CPC Plus practice cohort to be able to see if we can enhance their effectiveness on building that primary specialty care relationship, and then sharing those learnings with other practices within CMMI's programs. So with that, I'll hand over to Adam, who can talk about Arkansas Blue Cross Blue Shield specifically and their involvement in the program.
Thank you, Julia. So we do have some access and outcome challenges that are mentioned here on the screen, but we believe that eConsults can really help serve to kind of solve some of those problems, those challenges here. Wait times within some of our specialties can be up to 4 to 6 months before a new patient can get in to see that specialist, and that's just we need to do something about that. There's been some good work done in Arkansas around quality, but there is certainly always room for improvement, and we are looking to improve that, our quality. There's also been a lot of interest, due to COVID-19, certainly a strong interest in telemedicine and expanding that. But even as we move toward new models like capitation and in primary care first, there's certainly a need to increase telemedicine and access, and so we believe eConsults can help meet some of these challenges. Around value-based payment, our story at Arkansas Blue Cross with value started back in 2010 with a patient-centered medical home pilot with just a handful of clinics, 7 total primary care practices that participated. We transitioned into the CPC Classic model held by CMMI. And we were one of only 2 regions within that model that achieved shared savings. And today we have, as you see on the screen, over 90 or 94 CPC Plus practices that are in Track 2, and all together with all of our value programs, over 400 primary care practices and 1,500 primary care providers that are in a value-based model in Arkansas. And so we have a strong influence when it comes to value. We have a really large footprint or membership patients that are attributed to our networks, and we are trying to bend the cost curve and move toward value, and we believe eConsults can help us get there. As I mentioned, we are heavily involved in value programs and moving toward primary care first and the capitation model, and then some of our investments in Arkansas in our communities include, exercise equipment for our communities and schools, food pantries, behavioral health provider training, and more. And we're working with our local hospitals to get them connected to our state HIE so that we are sharing data and getting the providers the data they need to treat the patients. And we also have, as I mentioned, a large footprint in Arkansas, but that's due as well to our ASO clientele, where we are able to administer benefits for funded clients. And so with more than a decade of statewide collaboration to really change the payment paradigm, there are a lot of CBC practices that are ready to move even further into value. And so we think this means that there can be a high degree of readiness and motivation in the state for eConsults. Julia?
Great, thank you, Adam. So clearly a value proposition for Arkansas Blue Cross Blue Shield to be involved in this work. I think we've heard through the course of the conversations today about the importance of the value proposition for all of the key stakeholders within this work. And so from the PCP perspective, really being able to know that they can get timely access for their patients, and then through the educational component, building up that capacity to greater comprehensiveness for patients, for specialists, being able to use this kind of standardized and streamlined way to then support primary care, to retain management of patients where it's safe to do so, and then seeing those patients that do require an in-person visit, and then for the patient themselves, avoiding those unnecessary visits and the costs associated with those, while also getting timely access as is needed. So our approach on this work is essentially to run a demonstration for 18 months. We'll be implementing in 10 CPC Plus independent practices with ComforMed, and also 10 CPC Plus practices within a single system with Project Core. While we run the 18-month implementation effort, we'll also be evaluating with Mathematica, who will be supporting the business case for Arkansas Blue Cross Blue Shield, which we hope to be able to share with them at the end of 2022, as well as formative learnings for other practices within the CPC Plus network and beyond. By the end of the program, we hope that we have been able to demonstrate to Arkansas Blue Cross Blue Shield what they need to further reimburse for eConsults, and also to invest in the infrastructure and the capability needed to support greater adoption across the state. We hope to have been able to expand the evidence base about increased access to specialty care, improved outcomes and savings, and then also to have brought some of the large employers in Arkansas along with us so that they can see the potential of eConsults and be on board to supporting that broadening of adoption across the state. So with that, Timmy, I'll hand back over to you.
Thank you so much. And we will address the questions at the end of the session. And again, I'll remind everyone to put your questions in Q&A, or to also address individuals through the chat. So moving on to Dr. Amin, are you able to, let's see, can you turn on your video, please? There you are. And I think also unmute. Can you unmute? There we are. Okay,
yeah,
Dr. Amin.
Thank you. Today, Indian New Year, so I had some family obligations, so you've caught me on a casual day, but I wanted to thank you all for the opportunity to join today, talk about a project that I've been very passionate about. And we implemented eConsults at the University of California, Irvine a few years ago, and I've been very enthusiastic about the talks that I've heard this morning. Part of it is that, so just a little bit of kind of some context of and the work we've done on eConsult. So UC Irvine is it's a tertiary quaternary medical center in the sixth largest county in America, Orange County. It's 3.8 million people in the county. We're the only academic medical school or academic medical system, in Orange County. So we, a few years ago when I kind of started getting into eConsults, we actually had an EMR system that was all scripts. And so we actually embedded eConsults, designed it, and I embedded it into all scripts. And then we actually, a few years later, converted over to Epic. So we've had the experience of doing eConsults in all scripts and in Epic, which was great because we've been able to see success in both, and both systems are a little bit different in terms of the way we designed eConsults. We've got 17 specialties that we've done eConsults in on the ambulatory side. We started on the ambulatory side. We've completed close to 2,000 eConsults, and our success rate is 85 plus minus % of success in terms of completion of eConsults. And we've defined success as as a patient not having to actually go and see the consulting provider, right? So, and as a result of that, which we view as a huge success, we also measured, the time it takes to complete an eConsult, and most of our eConsults are done within 10 to 15 minutes. Almost 3/4 of them are completed in that period of time. So it hasn't been too much of a burden for our specialists across the board to complete eConsults. In terms, I heard a conversation earlier about, incentivizing and making sure that the providers are fully engaged in the process. And we have also done that. We initially started out with providing, $50 per eConsult to the primary care doctor and $50 for each eConsult to the specialist. And that worked out really well. And then we went through an entire organizational change called clinical integration in terms of our funds flow, and now we do things based on work RVUs. And so based on the work RVUs, we now give 0.7 work RVUs credit to each, the primary care doctor and the consultant. So following that, we kind of expanded out into our residents now do eConsults, our APPs do eConsults, and so forth. One other major experience, which we are coming close to 400 or 500 eConsults on, is we own 2 federally health qualified clinics, and those clinics, the unique issue is that we have our own faculty employed primary care physicians that work in those clinics, but because of insurance and authorization and contracting issues, many of those patients are not easily getting access to, the university specialty consultants. So yet our primary care doctors want to use our specialists, and the patients want to have access to our specialists. So we've self-funded internally to do eConsults for those patients, and that's been a huge success also with similar types of success rates. So, from a diversity and inclusiveness perspective, many of these federally health qualified clinics only have some of the underserved, and so we've been able to provide support to them for these eConsults. And then our last, we continue to evolve eConsults. Our continual venture into innovation is we've started doing eConsults on the inpatient side, and we're in the active process. I'm leading a group doing that, and we have now added on 7-8 specialties, and we've crossed over 100 eConsults, or coming close to crossing over 100 eConsults on the inpatient side over the past 6 weeks or so. And so it's been a learning experience in that regard, and completing, again, same definition that you can complete a consult without the patient ever having to see the specialist. And so that's been good. One of the things that I was asked to focus on also, so we're now in conversations with some of our county officials about, eConsults, and they want to obviously broaden it. I think there is a little bit of a difference in terms of eConsults when you look at it from the insurer's perspective versus the delivery perspective. From the insurer's perspective, they kind of need to make sure that they will have physicians from different provider networks, if you like, that may not be connected on the same electronic medical record system, have to develop a way in the cloud to do eConsults. And a lot of times, a lot of the information may or may not be in there, or the physicians have to input the information so that, a specialist from another network might be answering the eConsult. when you do it from the delivery side, which is what I call our side, we've got it's almost a closed system, and so you have a lot of the information already embedded into our EMR system. So it makes it, I think, a little bit easier for the requesting physician, because they don't have to upload all the imaging and upload all the labs and so forth, or type them in, because it's all within the EMR system. So there are some advantages of looking at it depending on how you end up designing the system. And then I was also asked to kind of talk about some of the process. One of the things we did about insurances and authorizations and Medicare, with the new guidelines, the requesting physician has to be able to, verbalize the consent for a patient so that they're aware that an eConsult is occurring, and the patient may actually get charged a copay, and so that's a process that we have to work through, and so we've done a multi-step process in it. In the general consent form, when somebody comes to UCI Health to get their care, we've added verbiage in there that states that they may end up having an eConsult as part of their visit, either outpatient or inpatient, which the patient sign. And then second, we also have a box that is checked by the physician that says that they've actually verbalized to the patient in order before the eConsult gets completed. And doesn't take any work for our physicians. The physician actually talks to the patient, informs them of the eConsult. The patient consents to it, and the physician informs them that there may be a copay, and then we have a checkbox that, when the physician is requesting an eConsult, they would, before they complete it, they just check a box saying that they have actually verbally consented the patient, informed them. And that's worked out really well for us. And we've been able to, the patients aren't surprised about the copay if there is one. We also instruct the patients that, the copay is heavily dependent on their own insurance, and their, and each patient has got different, it may be individualized for the type of plan or whatever the patient's on. And then the verbal consent is easily done by this checkbox, and it's well documented and meets all the Medicare rules and so forth. So we've had a great experience with it. We're thrilled, and we're continuing to innovate using eConsults. We believe that it's reduced risk for our organization. It's kind of helped us get away from curbsiding, which is more riskier, we believe, and so we're kind of hardwiring it as a process within our overall institution. So I think I'll stop there and hope that helped, and be happy to answer questions.
Thank you. And I think with both of our panel today, that we're clearly seeing eConsult being considered not only for when we started its beginnings in the Medicaid practices, that it is starting to make inroads in both commercial, clearly Medicare, and also being part of, or considered part of, advanced care models. And back to Dr. Barnett, I know that you have some thoughts around how eConsult can be considered, and I think it's crossing over in the work in Arkansas. You're moving away from fee-for-service and thinking about how eConsult can be considered as a key tool to be able to reach advanced care payment models, or care models within the PCP population.
Right. It's a great point, Timmy. And I think that, for a lot of these payment innovations, the idea is that, if we make things that PCPs need, then some form of capitation should really be all that they need to figure out what is the most efficient way to adopt a new care model within their practice. And of course, there's more than just simply giving them a capitated payment, right? We've talked a lot about the provider engagement piece. We saw that with telemedicine as well, and current adoption now, which is that providers aren't comfortable with, or they haven't been trained in a certain technology, or they're not quite sure how how it works culturally, then they may not adopt it. But I think that eConsult, as it becomes more widely accepted, really is, I think, part of the complete breakfast, if you will, of being kind of an advanced care practice. In part because I just view it as such a fundamental part of just the job of care coordination. Now that patients are seeing more and more specialists, they have more and more medications, there's more and more comorbidities to manage, that patients simply can't see a specialist every single time an issue comes up with their appointments, with their specialty care issue. PCPs need to be able to play quarterback by having some kind of more formalized way of communicating with them and actually being able to account for that in some way in their workflow and the specialist workflow.
And I'll move that back over to Julia and Adam. How are you thinking about, I know there's the project that is specifically the eConsult project, but how are you thinking about it in the future with your CPC Plus practices? So, who wants to take that?
I can take a stab at it, and Julia, you can comment on it as well. But Dr. Barnett, I couldn't agree with you more. We definitely need the PCP to play the quarterback and have that communication, that those airways open with the specialist. Right now, that just doesn't exist very much in Arkansas. Looking at billings dating back 4 years, there's just 20, 25 different times that a PCP has billed an eConsult code in Arkansas within Arkansas Blue Cross. So it's non-existent right now in Arkansas, but we're looking to make that change.
And Adam, do you want to also address, I know you touched on this for a bit, but the work that you do on behalf of your large employers in the state and how they may be also able to either champion or drive eConsult?
Sure. Certainly our large employers in the state have a lot of sway or voice in the state to be able to make movements and make change. And there's a lot of talk within our large employer groups that they want to move toward value. They want to make that change. And so we want to support them in their efforts. And so eConsults presents a way to do that. And as we move toward primary care first and that also presents a way, Dr. Barnett, you kind of alluded to this, and capitation creates the avenue for providers to be able to decide, okay, well, what does this patient really need, rather than just basing it on a volume perspective. So, yeah.
And I see a great question coming through the chat, but Dr. Barnett, before I go to you, can I just insert one more question here? And I think this is the connection with a conversation with large employers or those that are self-insured and Medicare, and Dr. Amin with the, just addressing, instead of seeing it as a barrier with the copay, but just embracing it and just adding it to your workflow. Can you just talk a little bit more about that? That I guess you're not seeing it as a barrier of needing to accommodate a possible copay.
Yeah. So the patients would have a copay if they went in and saw the consultant directly, with the long wait times and the access issues and the inconvenience that the patients would have and so forth. So we inform the patient that, this is not actually, we try to highlight the benefits of the eConsult and the value added that it brings, and that it's not, the copay would have existed regardless of eConsult or a regular consult, number one. And number two, the fact that we're able to do the eConsults, we can offer these additional benefits to the patient, which, many times, if I have to pay $20 or $25, but I get to sit at home and get an answer back. One of the things that I didn't give in our statistics, but most of, we have an 80% turnaround time the same business day or the next business day. So patients, to get an answer back quickly, is such value added that, that is the important aspect that I think we should be focused on. And that's the way we've gotten around it. We've not had one complaint about copay issues. I think the other thing I would say, one last thing, is that being transparent about it is really important so that patients don't feel like they weren't told that there could be a copay, right? I think people get frustrated when they're not informed, and so informing them that there could be a copay, goes a long way in easing their concern.
Great, thank you. And I think we'll continue to follow the growth in Medicare and Medicare Advantage and with the employers and seeing how we're able to manage, not look at it as a barrier, but manage the copay issue. Dr. Barnett, a question that came in was around what questions do you believe are going to be the most important to answer in the next round of eConsult related research? You may have some eyes into what we might be able to see as research being published around the corner, but what other questions do you think need to be asked and answered?
Yeah, absolutely. And thank you, Paul, for asking that question. I guess maybe before I answer that and kind of, muddy the waters here, I mean, I'd really love to hear from, for instance, like Julia and Adam, from your perspective. You guys are embarking on this program, having thought through everything you might want for, say, Mathematica to get you from their evaluation to figure out, is this worth the investment? I'm curious, kind of for you guys, what are the most important metrics that you've decided? And was there anything that you wish you could have measured, but it just wasn't practical?
Maybe I'll just give a little bit of context, and then Adam can talk a little bit about some of the specifics to the degree we're there. We're at the moment in the process of actually designing both the summative and the formative evaluation. And so from the perspectives of the business case, it's really about, from Arkansas Blue Cross Blue Shield's perspective, what would be most compelling to them and their decision making to both reimburse for eConsults, but also invest in future scale up and spread of the infrastructure and capability across the state. I think from the formative evaluation perspective, we recognize that payment is not the main barrier necessarily to practices, or certainly the only barrier to practices adopting eConsults. And so we really want to learn in there to what are the other motivators and what are the other barriers that do either facilitate or impede adoption. And we'll be working with people like Delphine and Timmy and others who are expert in this field to help us really unpack what are the core questions and what are the learnings that would be of most interest to other organizations that have identified the specialty primary care relationship as a key area for improvement, and eConsults as a way to try to solve that. Adam, is there anything you want to say specifically about kind of the metrics of interest or the ROI calculation?
Sure. Return on investment, I think, is going to be important as we think post-pilot. What do eConsults look like for our commercial population? So what we're looking at, are there cost savings, and how is that generated? Is that through reduction of specialty visits? Is that a reduction of specialty services that would have been administered within that specialty visit? Number of eConsults performed, and how many of those ended up in a specialist office versus were avoided, and things like that. So one of the things that we would love to be able to measure, we may not be able to do, is the patient experience within that, and as it relates to CAP scores and the impact that eConsults can have there. We're working with Mathematica on it, but I think the only way to go about measuring that would be to actually field a new CAP survey. And one thing we know for sure is that our members receive lots of different types of surveys around the care they receive. And so we want to be cautious and cognizant of how many surveys we're sending out.
Great. It's really, really interesting to hear your perspectives on that. I'll share as a researcher, part of what I'm working on and what I've seen is I definitely agree with Julia around kind of costs is maybe a bit of a secondary outcome that at least I think about these days. One challenge with eConsult is that specialty care is both underused and it's also grossly overused, right? And so really what we want to do is try to make care more efficient. And when you measure kind of average outcomes like wait time or costs alone, you're kind of squishing together both overuse and underuse. But the challenge, of course, is that appropriateness is very difficult to judge as well. So some of these outcomes, I think, can be helpful to measure in aggregate, but I don't necessarily view it as a failure or seeing that or that eConsult's failing to meet expectations if we don't see a cost saving in some evaluation. One thing that, and I'm curious to hear the other panelists' views on this, one thought that we've been pursuing in some of our evaluations is actually trying to use the PCPs themselves as a metric of understanding the value of certain eConsults and building into platforms the ability for us to see the extent to which an eConsult actually changed a PCP's course of action or influenced what they do. Because appropriateness is difficult to judge if you're just doing chart review. But PCPs, they know what was valuable to them, and it's potentially something that's actually pretty easy to work into a relatively vast survey or into some platform. And that's a little bit of a pipe dream to kind of imagine an EHR change of that magnitude. But my thinking has drifted towards trying to measure kind of appropriateness in clinical decision making is really one of the key intermediate steps that we have to measure, because the downstream, measuring all the downstream stuff that we see in claims, like for instance, the rate of advanced imaging or change in costs or change in avoided specialty visits, it really conflates this underuse and overuse problem, which PCPs see on an hourly basis, but is very hard to measure in aggregate unless I think you can kind of go to the source.
Yeah, I think it's a very interesting question. We certainly won't be trying to measure appropriateness in the context of our study because it's very difficult to be able to link the data sets to truly answer that question. From our perspective, one of our key focuses is really about, is there the proof point there for the commercial payer? Obviously, there's always the risk from a commercial payer's perspective that it will add to cost. And I take your point earlier that it's not necessarily cost savings that should drive high quality services that improve patient outcomes. But from a payer perspective, it's obviously an important part of the equation and therefore an important part of further scale up and spread of eConsult. So that's really our kind of priority in this work, while we also do try to do some work at the practice level to understand some of the questions that you're asking. And we will be doing provider satisfaction surveys and experience surveys as we go through the formative work, and trying to actually get to a place where we have typologies for our formative learnings around the type of practice that you are and the type of motivators and the context that you're in, and therefore the approach that you might take and how you would implement this model. So that's another way we're sort of trying to get at some of the differences at the practice level.
I'll add, we want to make sure that the members, the patients, are getting the right care in the right setting. So if they need to go to the specialist, then they need to go to the specialist. But if the PCP can handle it, maybe they're not sure about it, so they're going to do the eConsult and get some information and direction from the specialist and be able to handle the situation or issue right there in the PCP's office. That's better for the member because they're going to see one provider rather than two. They're not having to take off of work for 2 different visits. I mean, there's lots of value other than just the financial side of it as well. So I agree with you.
Well, thank you. I applaud you all as being part of this panel and pushing us forward, breaking new ground on the commercial side. Dr. Amin, with your approach to Medicare, it's very refreshing to hear. And Dr. Barnett continuing to keep us focused on what's next. Thank you. And I wish that we were in at this point, a conference hall where we could all hear the applause. But thank you for your insights today. And I'm now going to pass it back to Libby for our lunchtime review for reporting and also not only reporting, but reimbursement.